Good morning, everybody.
Morning.
Good morning.
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 Good morning.
I see Dr. Megendig. I heard Dr. Weber. Pretty sure I heard Dr. Marshall. Let's see if
He's on. Well, I see his name.
Yeah, I'm here.
There he is.
I see Brian. And let's see. Do we have Dr. Shaw yet? See Dr. Patel.
Yep. Good morning, everyone.
Looks like maybe we're missing Dr. Shaw still and Dr. Krupp I don't see yet. So we'll give them a minute or so here to join. My dogs are being very vocal today, so apologies in advance. I already kicked one of them outside, but two are still in here and they're making themselves known already this morning.
Hey, Amanda, why don't you take a moment just to kind of explain to everybody why we are virtual only today?
Surely. For this particular meeting, we are virtual only because we did not have access to the equipment at the state to be able to hold the virtual meeting. We wanted to make sure everybody could hear everybody okay, so we were worried that if we used a tiny Polycom speaker in the facility that everybody on the phone that joins virtually wouldn't be able to hear us. So we just, the state decided that we would just do the entire meeting virtual so everybody could hear and be able to know what was going on in the meeting. So that is the reason that we are virtual this morning. So appreciate everybody for what's the word I want to use? Being flexible with us and heading down that path.
Thank you.
Oh, thank you. You will still don't see Dr. Shaw yet, so.
Yeah.
Oh, is that you on the phone, Dr. Shaw?
Yes. So the meeting today is virtual. I'm actually in the Wasatch room.
Oh no, yes. It is virtual only today because there was no equipment. So
Okay.
I'm sure, I think, John, do we technically still have the room? Like if Dr. Shaw wants to hang in the room and join from there, he's able to do that, right?
Actually, he can check and see. I think as soon as we figured out that because they were unable to produce the equipment, we were not going to really have use of the room. We probably turned it back to them, but he can go and check and see if it's been taken up. So, if not, he's more than welcome to come up to one of our offices, and we can set him up in one of our offices upstairs if he'd like.
I am okay down here. The little posting outside the door inside the room is reserved for us.
Okay. Why don't I have one of the pharmacists from my team go down and guide you up to our offices real fast? How's that sound?
He said it was reserved for Therapeutics committee still.
Oh, okay. I'm sorry. Well, then park yourself. That'd be great. Yeah. Sorry, we are experiencing some issues with our the facilities folks that we will be getting rectified So.
Okay.
Yep.
I am having difficulty joining through Teams, so I don't have video.
Okay, but you've got all the documents and everything, so you're okay to follow along, right?
Yes.
Okay, perfect. I think then we definitely have a quorum. We're short one individual, but I will keep an eye out for them to see if they join here in a little bit. And I think if you're ready, Dr. Shaw, I can start with our normal announcements and then we can move through the agenda.
Sure.
Okay. So just a couple announcements. For one, this is being recorded. So just FYI, as per usual, we are recording the meeting. If you are not speaking, if you could please mute your line just so we eliminate some of the background noise. And per our usual meetings, I will take roll call voting when we get to items that we need to vote on. You can aye, nay, or abstain. And I will go through that list as we get to the voting, and I will help with kind of driving our agenda as we go through. And also a reminder, we do have sign up for public comment. We do have individuals that have signed up, so we'll make sure we capture those individuals as we get to that section of the meeting. With that, I will turn it over you to Dr. Shaw to do the call to order and any opening comments you have.
No, I appreciate it. I have nothing to mention, so I'll give it back to Optum and OPM.
Sounds good. All right. Mr. Ross, any opening comments for you all?
No, I appreciate everybody's being here. We continue to have issues with getting the appropriate number of members on our DUR board. I have actually been in the office of Dr. Gloria Sachdev, and she is personally taking this on to make sure that we get some folks brought over from the governor's office, nominated and put in. So we are quickly trying to rectify that. I don't want to ever give the impression that we are not taking that board seriously. We need those folks, and we are looking forward to getting that board up to speed very quickly. So appreciate your patience on that as well.
Thank you. And John, I don't know that this committee knows yet, but did you want to tell them about your new role?
Oh, yeah, I get, okay, yeah. So as you guys probably are aware, Leslie Lugo left the state in November, and a couple months ago, I was moved up into her position. So I appreciate your condolences for, if you want to express them, for taking it on, but no, I'm happy to take up the mantle and looking forward to working with my team and of course Optum and everyone here. So thank you.
Congratulations, Sean. We're happy for you.
Thanks, Brian.
Congratulations.
Thank you, sir.
Thank you. With that, then, Dr. Shaw, we are ready for the approval of the memoranda from the February 7th meeting.
Yeah. So we have the memorandum submitted by Optum. All right, let me close the door. Are there any comments or edits to the memoranda?
I'll make a motion to approve.
Okay.
Dr. Marshall, second.
Okay. Thank you. If there's no further comments or edits, all in favor?
Oh,
All
Aye.
right. Do we need to
Aye.
roll call, or we okay with?
We'll do the roll call, yeah. Sorry. So we have a motion in a second. Dr. Shaw?
Aye.
I'm just checking really quick to make sure I didn't see Dr. Krupp join secretively. All right. Dr. Marshall,
Aye.
Mr. Musial,
Aye.
Dr. Negendank,
Aye.
Dr. Patel,
Aye.
and Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Our next item on the agenda then is our review of the preferred drug list. So we will go ahead and get started. So in the CNS and others recommendations, we have no recommended changes in the classes listed here. For the gastroprotective agents, naproxen, esomeprazole, moving to non-preferred. For the movement disorder agents, the Austedo IR titration kit, removing from the movement disorder agent PA as well as the SUPDL, as it is no longer manufactured and CMS termed. Or sorry, no longer manufactured, not participating in the MDRP. It's technically not termed, it's just not participating. For the narcotics, there is a new strength of tramadol, 75 milligram tablets, maintaining its current status, but adding it to the opioid overutilization PA with a age limit of 18 years of older, and a short-term use of 4 tablets per day for a quantity limit, and then those with long-term use, a quantity limit of 5 tablets per day. For the skeletal muscle relaxants, the brand Lorazone is no longer manufactured in CMS terms. They're recommending removing from the SUPDL. For the smoking deterrent agents, varenicline maintaining its current status and age limit, but adding a quantity to the therapy pack of the 1 pack per 90 days. And that concludes the CNS and others. For the dermatologic agents, we have no recommended changes in the classes listed here. For the acne agents, the BP 4.25% cleanser and the Myorsan brand only are both no longer manufactured in CMS terms, so I'm recommending removal from the SUPDL. And that concludes the dermatologic agents. For the endocrine recommendations, we have no recommended changes in the classes listed here. For the bone resorption inhibitors, abandronate tablets moving to preferred. For the GLP-1 receptor agonists and combinations, the exenatide, the generic Byetta, moving to non-preferred, adding to the GLP-1 combinations PA with drug-specific PA criteria. And basically what's happening is the brand Byetta is preferred, but it's really no longer available. And so the generic will not be required to meet the generic medically necessary criteria, but it is going to be non-preferred. And then liraglutide and Ozempic and Victoza maintaining their current respective statuses, but updating initial authorization and reauth criteria for the MASH and MASLD diagnoses regarding the accepted diagnostic tests. And then we are looking to add Wegovy and Zepbound now to this class on the PDL. For Wegovy, it will be non-preferred. It was previously neutral. It will be added to this PA criteria. It does already have drug-specific PA criteria associated with it around the CVD risk. So that will be included within this PA now. And then Zepbound also has been neutral with PA. It is going to be preferred, and it does have criteria surrounding it around the OSA diagnoses. And just want to make a point that the use for both of these agents strictly for weight loss alone is still not reimbursable in the state, but use for other diagnoses it is. And you'll see that within the criteria as well. All right, for the insulin's intermediate acting, the insulin aspart 70/30 FlexPen and Vial moving to preferred. And then the Novolog mix 70/30 FlexPen and Vial moved to non-preferred. So just doing a switch between those two there. For the insulin's rapid acting, Fiasp cartridges, FlexTouch and Vial moving to preferred, Humalog Vial moving to non-preferred, and then the insulin Lispro Vial moving to preferred. So switching the Humalog with the insulin Lispro. And then for the insulin acting, the insulin Glargine, the Winthrop brand is no longer manufactured. So removing that from the SUPDL, and we no longer have to distinguish the Winthrop brand specifically. For the miscellaneous oral anti-diabetic agents, to make these consistent with the other step therapy that we have in place for products, we are recommending removing the step therapy from glipizide metformin, glyburide metformin, and the pioglitazone. And then the testosterones, there is a new testosterone cypionate as Miro, adding to non-preferred and the testosterone specific PA criteria. And then the testosterone 1%, 50 milligram per 5 gram gel packets moving to preferred, and then updating the criteria to reflect its preferred status. And that concludes the endocrine agents. For the estrogen and related agents, we have no recommended changes. For the gastrointestinal agents, we have no recommended changes in these classes. For the H. pylori agents, Helidac is CMS term, so we're recommending removing that from the SUPDL. For the proton pump inhibitors, Athafex, the brand-only product, is no longer participating in the MDRP, so we need to remove that from the SUPDL. And then we wanted to make an update to the proton pump inhibitors PA around the reauthorization, and I'll try and explain this a little bit just to make sure everybody's on the same page. So as you hopefully remember, we do have PA around individuals that are exceeding 90 days of therapy in the past 180 days. This is so that we can make sure that people are using intermittently unless they have other diagnoses or disease states that would reflect continuous use, since we know there are several risk factors associated with long-term use of PPIs. So one of the things that we have now noticed since we've had this PA in place for quite some time is that most of the individuals that are continuing long-term use are the same individuals. We're seeing them over and over again, and we're having to grant them a PA. We did not want to put a lifetime PA in for these individuals because we do change preference status for these products, and we didn't want that to impact how we moved preference. So what we decided to do was that if somebody does have therapy that was previously granted a PA for long-term use, that we'll put in an automation that will allow that to continue, assuming they're still using the preferred status. So this allows us to hopefully decrease that prescriber burden and member burden for PA for those individuals who really should continue or need to continue PPI therapy long-term, but still prevent those individuals who shouldn't maybe continue PPI therapy long-term from accessing therapy long-term just automatically. So there was a discussion about removing the PA altogether. But for those of us who were around back in the day when we added this PA, you might remember that we had everybody, it seemed like, using PPI therapy. And so we've really kind of curtailed that by having this in place and having that long-term therapy. And so the concern is that if we would remove the PA altogether on that we would again have that really high increase in utilization without people using intermittently. So that was kind of the approach we decided to take. Any questions on that? All right, awesome. We'll move on then to the ulcerative colitis agents. Orticos is no longer manufactured and no longer participating in the MDRP, so we're recommending removal from the SUPDL. And that concludes the GI agents. For the genitourinary agents, for BPH, the Avodart brand only is no longer participating in the MDRP, and the Entadfi is no longer participating in the MDRP. So we need to remove both of those as well. For the urinary tract antispasmodic anti-incontinence agents, Gemtesa, maintaining its current status but updating its step therapy that the member must have trialed and failed Myrbetriq, or that the prescriber has provided medical justification for use of Gemtesa over Myrbetriq. And then the tolterodine IR and ER, moving both of those to preferred. And that concludes the GU agents. For the hematologic agents, we have no recommended changes in the classes listed here. For the platelet aggregation inhibitors, Durlaza is no longer manufactured in CMS terms, so we need to remove that from the SUPDL, and Zontivity is CMS terms, so we need to remove that as well. And that concludes the hematologic agents. For the topical agents, we have no recommended changes. For the miotics intraocular pressure reducers, metoprolol is no longer manufactured and CMS termed, along with the Timoptic XE brand only. So we need to remove those from the SUPDL, and Simbrinza moving to preferred. In addition, Vuity maintaining its current status, as well as updating the quantity limit within the presbyopia PA to allow for 1 bottle of the 2.5 mils every 10 days or the 5 mils every 20 days. The ophthalmic anti-inflammatory agents, Prolensa solution moving to preferred and maintaining its status on the preferred brand drug list. For the ophthalmic mast cell stabilizers, as you can see here, the Alacryl and the Alamide are both no longer manufactured in CMS terms, so this leaves us with a class of just cromolyn. And so we are recommending removing this drug class altogether, since there really is no rationale for maintaining it on the PDL anymore, and just having cromolyn be a neutral product and accessible. For the topical antiparasitics, Lindane shampoo is no longer manufactured in CMS terms, so we need to remove that from the SUPDL. For the topical post-herpetic neuralgia agents, Sanera is also no longer manufactured and no longer participating in the MDRP, so we need to remove that from the SUPDL. And that concludes our review of the drug classes. Any questions before we go on to new business? Lots of removals this quarter. All right, I am hearing none, so we will go on to new business. Any new business before we discuss the opioid statistics from the committee? All right, hearing none, we will then talk about the opioids. So this is the data from March 2025. So we did have a slight increase in total utilizers from February, as well as an increase in new utilizers. And I know you don't see the data before this, but really we had some decreases. And so that's why I think we're seeing just a slight increase again. It's kind of just fluctuating a little bit. Our utilizers under 18 has been pretty steady in the less than 5 days for use, which is what we would like to see. You can see the breakdown of the number of utilizers versus those that are PA exempt. And so just a reminder, everybody in the 500 MME and above is exempt. And so technically we have nobody that's utilizing in those groups that don't have a PA exemption. We are working our way down. I believe in April, we went down to 400. Is that right, Courtney? Or are we 425?
I'm pretty sure we're at 400.
Okay, that's what I think too. So we're at 400 MMEs now. So we're still working our way down there, but we are making some headway. So continuing to work our way down. So if we look at some of our trending graphs, this is everybody above 90 or 90 and above. So that and they do not include those that are exempt from a diagnosis. So again, most of our individuals are in the less than 90 or in the 90 to 120 range. We have very small amounts in the other groups.
I lied. We went down to 375 on April 1st.
Oh, 375. Thank you. Appreciate that. We're even down a little bit lower. So here's our trending over time. You can see just kind of that steady decrease. We do know that some of this is likely due to pathways moving out to the MCO partners, since we did lose those members. And that movement happened in July. So you can kind of continue to see that steady overall decrease. That being said, even since pathways have moved out, we've continued to kind of have this low, steady kind of decrease over time. So we're continuing to monitor it. Like I said, there was just a slight increase in March, but really, as you can see, January, February, and March are pretty consistent with where we've been. Just a reminder, the emerald-ish green color is our current utilizers that are adults. The cranberry-ish color is the new utilizers, and then the purple color up at the top is those that are under 18. So if we look at our trending graph based on our MME, you can see the less than 90 kind of has had this, again, a little bit of a decrease and then is kind of leveling off now. And so we may expect to see, a fair steady state here now that we've had some of the movement of the population. And then if we look at all of the other doses, you can see everything above 500 is very steady. It's the same individuals that have been on that. You could see kind of that slight decrease in the 250 to 500, which is what we would expect because we're moving people down out of that. That's the orange color up there. I believe it looks like a dark green or a blackish color. You could see the slight increase in that, which is also what we would expect because we're moving people down the dosage range. And so they may be moving into that kind of next stacked dose. You can see that kind of sharp decline in the 90 to 120 around the time that we had pathways move, and then it level out as well. Any questions on the trending graph? Or any of the opiates for that matter? All right. Oh, go ahead, Dr. Shaw.
No, sorry. Someone just joined over here.
Oh, okay. Not a problem. I am going to pull up, if I can find my clock here for public comment. So we will be ready for that because that is what we are going to move on to next. So next up we have public comments. We will just have you unmute your line as we get to you, and a reminder, there is 2 minutes for public comment. So first up we have Dr. Laffey.
Good morning, everybody. Members of the P&T committee, my name is Taylor Laffey, and I am a pharmacist with Indivior's Medical Outcomes and Value team. Thanks for allowing me to share some important updates on Sublocade buprenorphine extended release injection with you all. Sublocade has had label changes as of February of this year. I'll run through some information about it. Sublocade is indicated for moderate to severe opioid use disorder in those that have had initiated treatment with a single dose of transmucosal buprenorphine or are already being treated with buprenorphine as part of their treatment plan. There is a box warning due to the risk of intravenous administration resulting in serious harm or death. So Sublocade is only available through our REMS program. Warnings and precautions include the risk of addiction, abuse, misuse, risk of respiratory depression with other CNS depressants, and also injection site reactions. So for patients not currently taking buprenorphine, they should receive just an initial dose of transmucosal buprenorphine before administering the first 300 milligram injection of Sublocade. The recommended dose for the second injection is 300 milligrams. This is also a change in that second injection may be administered as early as 1 week, up to 1 month after the initial injection based on patient need and provider assessment. After the first 2 injections, maintenance dosage should continue with either the 100 or 300 milligram dose, and the maintenance phase should be separated by at least 26 days. Last update is that Sublocade can be injected into additional injection sites. In addition to the abdomen, we now have the thigh, buttock, and back of the upper arm. Based on research, Sublocade was specifically designed to achieve and maintain a sustained buprenorphine plasma concentration at levels predicted to block the lagging effects of other full opioid agonists. Thanks for your time.
Thank you. Any questions for Dr. Laffey from the committee? All right, thank you, Dr. Laffey. We will move on then to Andrea Hawkinson for Carbaglu.
Yes, good morning. My name is Andrea Hawkinson, and I am a medical science liaison with Recordati Rare Diseases. Today, Recordati Rare Disease is making a request to the Indiana State P&T Committee in support of patients with rare urea cycle disorders, or UCDs. So the availability of ammonia-lowering medication is essential to patients who suffer from UCDs. Recordati Rare Diseases would like to thank the committee for maintaining Carbaglu carglumic acid tablets for oral suspension 200 milligrams as preferred over generic carglumic acid for adjunctive treatment of acute hyperammonemia due to propionic acidemia, PA, or methylmalonic acidemia, MMA, adjunctive treatment of acute hyperammonemia due to NAGS deficiency, and maintenance treatment of chronic hyperammonemia due to NAGS deficiency. So hyperammonemia is a medical emergency, and therapies do need to be started as soon as possible to prevent decompensation and death. And individuals with NAGS deficiency, PA, and MMA do not break down nitrogen correctly, resulting in toxic ammonia accumulation. Therefore, checking the ammonia levels of newborns is one of the key ways to identify these rare genetic conditions. The guidelines for diagnosis and management of UCDs by Haberle in 2012 are still in effect and recommend Carbaglu as first-line treatment for NAGS deficiency. Haberle also pointed out the potential toxicity of repeated boluses of sodium benzoate or phenylacetate. The most common adverse reactions with Carbaglu are vomiting, abdominal pain, pyrexia, hemoglobin decreased, and headache, and additional safety and efficacy details can be found in the full PI. As the only carglumic acid approved for NAGS deficiency management and acute crisis stemming from hyperammonemia due to PA or MMA, we thank the committee for maintaining Carbaglu as the preferred agent, given the key differences in the indication. Thank you for your time.
Thank you. Any questions for Andrea Hawkinson? All right, thank you very much. Next up, we have Brett Stevenson with Zorev. Brett, are you on? Let me. Do not see Brett, so we'll come back and check here shortly. We'll go on to the next individual then. I believe it's Dr. Hamoud with February.
Yes, thank you. Can you hear me okay?
Yes, we can.
Yeah, well, thank you for the opportunity. My name is Jalal Naid Hamoud. I'm pharmacist by training and MSL here at Medunique. Today, we'll be speaking for Fiburain as a treatment option for urea cycle disorder. Sodium phenylbutyrate is a nitrogen scavenger drug established a decade ago as the gold standard adjunctive therapy to the standard of care of urea cycle disorder. A life-threatening condition has changed the prognosis of this condition by saving the patient's life and improving drastically their outcomes. Sodium phenylbutyrate non-coated formulation had been used since 1987 and was approved for marketing as Bufenil in the United States in 1996. However, bad taste or taste aversion are among the most frequent adverse events reported with commercial non-coated formulation of sodium phenylbutyrate and may cause taste disturbance and vomiting at intake, which make their chronic use very difficult and may reduce treatment compliance. Since commercial non-coated formulation of sodium phenylbutyrate granules have been offensive taste, an improved tasteless pellets formulation of sodium phenylbutyrate, Fiburain, was developed whereby coating of individual pellets results in formulation which has no immediate taste. In French compassionate program cohort, in comparison with the non-coated formulation used before entering the cohort, Fiburain showed high acceptability, no vomiting, and ease of administration without any reconstitution and improved control of ammonia plasma levels, with no hyperammonemia crisis up to 30 months. Medunique offers an accessible option, Fiburain, the first palatable FDA-approved sodium phenylbutyrate for UCD patients, to help improve their compliance, thus their outcomes. Therefore, we respectfully request to include Fiburain as preferred in your product list agreement, and I'm happy to answer any question you might have. Thank you.
Thank you. Any questions for Dr. Hamoud? All right. Thank you very much. Appreciate it. I still don't see Brett Stevenson, so we will go on then. And Joe, I know I should know how to pronounce your last name by now, but is it Cirencione or Cirencione? I forget every time.
Cirencione. No, you do it right. Thank you. Yeah, hi everybody. My name is Joseph Cioni. I'm a pharmacist and health outcomes liaison with Insight. Today I'm going to talk about Opzelura. Opzelura is approved for the topical short-term and non-continuous chronic treatment of mild to moderate atopic dermatitis, patients 12 years of age and older. Also for the topical treatment of non-segmental vitiligo in adult and pediatric patients 12 years of age and older. Please refer to the PI for the full indication statement. Insight respectfully requests that Opzelura remain a preferred product on the PDL, but with updated PA criteria of a trial of a topical corticosteroid or a topical calcineurin inhibitor, making the criteria similar to other preferred agents indicated for atopic dermatitis. Opzelura is the only FDA-approved topical JAK inhibitor, specifically for the treatment of atopic dermatitis as far as efficacy goes. After the 8-week vehicle control period in Opzelura's 2 phase 3 clinical trials, patients could enter a 44-week open-label extension. At the end of the 44-week extension, over 70% of patients who applied Opzelura as needed achieved clear or almost clear skin, and mean affected body surface area was between 1.4 and 1.8% based on treatment group. As far as additional studies and analysis go, an indirect treatment comparison of agents used for atopic dermatitis showed Opzelura had a lower number needed to treat compared to Eucrisa, Zoryve, and Vtama, as well as biologics such as dupilumab, and a similar or lower number needed to treat to oral JAK inhibitors. Lastly, a retrospective observational cohort study using 12-month US claims data showed that after starting Opzelura, patient used an average of just over 2 tubes in 12 months. Over 91% of patients remained biologic-free during the 12-month period, and over 26% of patients did not continue their biologic therapy from baseline. As far as safety goes, the prescribing information for Opzelura includes box warnings for the risk of serious infections, mortality, malignancy, major adverse cardiovascular events, and thrombosis. The most common adverse reactions occurring in greater than or equal to 1% of patients treated were nasopharyngitis, diarrhea, bronchitis, ear infection, eosinophil count increase, urticaria, folliculitis, tonsillitis, and rhinorrhea. In summary, Insight respectfully requests that the committee keep Opzelura as a preferred product, but update the PA criteria to a trial of a topical corticosteroid or topical calcineurin inhibitor. Thank you.
Thank you. Any questions from the committee? All right, thank you very much. We'll check really quick to see if Brett has joined. I don't see him.
Hey,
So
this is Dr. Marshall. What is the difference in the PA now from what he's asking for Opzelura?
I'm pretty sure it says and instead of or, but yeah, Courtney's nodding at me. Yeah, so we were requiring a trial of both and not
Okay.
just a trial of one or the other.
And it's the steroid and the JAK inhibitor, or
Steroid and a
Steroid.
topical calcineurin inhibitor.
Yeah, 30
I'm
days
sorry,
a
a
week.
what?
Calcineurin inhibitor.
Yeah, okay. All right. Thanks.
Thank you.
Thank you.
Next up, we have Dr. Odabayi for Austedo.
Hi, good morning. My name is Mimo. I'm a pharmacist with Teva Medical Affairs. I just want to thank the state of Indiana for continuing allowing access for Austedo and Austedo XR. So yeah, I would like to yield my time back.
Thank you. Appreciate it. Next up, we have Dr. Warner Greer for long-acting injectable buprenorphine.
Morning, everybody. Thanks for some time to talk. I'm Carolyn Warner Greer. I'm the Medical Director of Addiction Recovery at Bowen Health in Northern Indiana. I've spoken to the committee in the past before, but continuing to have the same struggles based on what we consider not helpful prior authorizations for the use of long-acting injectable buprenorphine in qualified patients. The limitations from getting stuck up against prior authorizations mean that you limit the ability to continue treatment. And in this patient population, discontinuation of treatment increases the risk of opiate overdose and death, as well as just simply leaving treatment and not being able to get patients re-engaged again. Long-acting injectable buprenorphine has been a game changer in addiction recovery. Many of our patients live in areas where they're either not allowed to self-administer medicine or they have a difficult time doing that due to safety and security, or simply just manifestations of early recovery as far as not having a lot of self-regulation and taking a controlled substance exactly as prescribed. This has been, again, at Bowen Health, has been a significant improvement for us, that we've been able to keep patients out of the hospital and safe from overdose, and even in opioid abstinence when possible. We also appreciate the delivery of long-acting injectable buprenorphine is certainly preferable to the kind of crapshoot sublingual medicines are, as far as patients have a continuous steady state of medication and don't have to keep triggering that limbic system over and over again. Is it time for pills? Is it time for pills? Is it time for a pill? We're still struggling. It's most prior authorizations. It's taking an undue amount of time for our staff. We will continue to try as hard as we can, but we'd appreciate some relief from the committee. Thank you very much.
Thank you. Any questions for Dr. Warner Greer? All right, thank you very much. Next up, we have Dr. Johnson.
Are you able to hear me?
Yes, we can.
Okay, wonderful. Thank you. Thank you so much for a couple of minutes to talk. I echo everything that Dr. Warner Greer has said. Also wanted to add, maybe if asking for removal of prior authorizations is the big ask, a smaller step in the ask would be continuing to request the removal of the requirement to try and fail Sublocade before a patient could choose Brixadi as their long-acting injectable buprenorphine option. And actually, I think it's a more moderate ask than this specific request has been in the past, given the new Sublocade labeling that was recently FDA approved. So we've expanded the number of patients willing to do the Sublocade trial first, which is excellent. There are still patients for whom they have a great fear of or a negative association with specifically the Sublocade injection, and to give more options and some autonomy to them and increase the chance of engaging them in treatment and retaining them in treatment, removing that requirement would be a huge help. I have one specific representative patient, 31-year-old male, very unstable housing, has had his sublingual buprenorphine stolen on several occasions, and has had a family history of mistrust with healthcare, which is completely understandable given his family members were put on high-dose opioids in the past, and that's part of what led him into this development of opioid use disorder. So to give him some autonomy in the situation, with him requesting to have Brixadi and us telling him you must have tried and failed the Sublocade option first for that particular patient, it's preventing him from being engaged in retaining in treatment. But again, I think it's a more moderate ask than it's been in the past, and it would be important to have as many options as possible, really to save lives and prevent fatal overdose in many of our patients. And just to say thank you for everything you guys have done to treat this disease.
Thank you. Any questions for Dr. Johnson? Thank you very much. Next, just check and make sure I don't see Brett yet. I do not. So we will go on to Abigail Hada with Ravicti.
Thank you and good morning. Due to no proposed changes in the urea cycle disorder class of drugs and access to Ravicti, I will yield back my time today to the committee. Thank you.
Thank you. And then I'm going to do a last call here for Brett, just to make sure I'm not missing him somewhere on the line before I go to our last speaker. All right, then our last speaker is Heather Metzger.
Hey, can you hear me talking?
We can.
Oh, okay. So I just wanted to bring a couple concerns regarding our access to LAIs with something that might be a little bit different, but some barriers that I have been noticing with specifically surrounding specialty pharmacies. So recently I had a patient that had suffered over 20 overdoses, and he had court-ordered treatment, but unfortunately, the facility in which he was placed required that he only get injectable buprenorphine, and unfortunately, because of the administrative processes or policies or whatever, the specialty pharmacy that we had to utilize because of with his Medicaid, it took almost an entire month. And unfortunately, this individual was actually incarcerated. He did end up getting the injection, but you know, it's just difficulty with specialty pharmacies having different processes and delaying care. Another example that comes to mind is also I had a patient that needed another injection. He'd gone to inpatient treatment previous. I sent the prescription over on 4/16, and the same specialty pharmacy that I was speaking about before did not even initiate the PA because of their administrative processes until 4/26, or I'm sorry, 4/28, and he was due for the injection 4/26. So it's just significant delays in care with that. And then another thing I wanted to bring to light is I think it's important for patients that struggle with the whole depot thing with Sublocade, the palpable depot, that isn't part of Brixadi's technology, and the depot can be very triggering to people. And I do know of cases where patients have actually cut this out and tried to suck on it to access the buprenorphine. So when talking about parity with the injectables, I just think that's important to point out, and I just ask that you take that into consideration, and also that we potentially could choose the specialty pharmacy that best works with our patients as well, not be forced to only utilize certain ones. Thank you.
Thank you. I know from the fee-for-service benefit perspective, we allow all specialty pharmacies as long as they're enrolled in the Medicaid program, but that may be something with the managed care. So again, I would urge you to send examples where you're having issues so that we can direct those to the appropriate individuals so that they can have that assessed. If there's a specialty pharmacy that's being difficult, because I do think the managed care has the ability to select certain specialty pharmacies, but from our perspective, you are able to use any of them as long as they're enrolled in the program. So examples will help us direct those to the appropriate groups. Any questions from the committee for Heather Metzger? All right, I am hearing none. Thank you very much. So that takes us then to our other business on the agenda, which we have the LAI buprenorphine discussion listed on the agenda. And I don't have a slide for that, but I know that there has been some discussion as well. We aren't recommending any changes to date on the LAIs. We could certainly, we'll have some additional discussion during the second session or our closed session. But anything that the committee wants to bring up about that now?
Amanda, this is Zach. I just had a quick question. We had a good discussion at our last meeting about this same issue, and we had asked several of the representatives that spoke at that time to be able to provide examples of some of the concerns that they were noting specific to the fee-for-service population. And I was just curious if Optum had received any of those examples, and if any of the concerns, that they brought up were noted in those examples, just something as the committee that we, should be aware of, and as you mentioned, that you're always looking into those, if those examples are shared.
Yeah, so we did receive one set of examples, actually just recently from an individual, and all of those examples were managed care examples. They were escalated to the various managed care groups that were a part of that. Because they're not fee-for-service patients, I'm not sure of the outcomes of those. I know, Dr. Kuhn or Mr. Ross, do you have any feedback from that since you all escalated those over? I don't know if you heard any follow-up. Again, like since they're not fee-for-service patients, I wasn't involved in that. But there was, what was there, maybe 3 or 4 patient examples that were sent over that were managed care, if I remember correctly?
Yeah, hi, this is Ann Kuhn with OMPP. It did involve 2 different MCEs. I know that one of the MCEs was able to reach out to the provider and have a discussion with the issues that they were having. I know that the other MCE was working on them. I am not sure. We never closed the loop on the follow-up piece. So, but they were at least in the investigation stage. I don't know if they came to a resolution and were able to reach back out to the provider.
And like I said, Dr. Weber, it was fairly recently sent. I want to say within the last couple of weeks, maybe. So that's probably why they're still doing some research.
Okay, no, that's fine. Thank you for the update. Like I said, I know we had a good conversation at our last meeting, so I was just curious if other examples had come forward. So thank you for the update.
Yeah, that is it. But I continue to encourage examples, please. Like we want to rectify if something is happening. Like we want to see those examples, and I would again encourage, like if you're having issues with a specialty pharmacy that a managed care is, saying this is the only one you can use, definitely escalate that so that they can review that with that specialty pharmacy. Any other comments or discussion? All right, so just a reminder. Oh, sorry, go ahead. Actually, I don't, since we're outside of the public comment period, I'll let Dr. Shaw, would you like to let Ms. Metzger further comment?
I just had a question about what you had just said.
That's probably sure. Go ahead. I don't if it's just a question.
Sure. So I'm sorry. I don't know all of the terminology. So when you say, so for example, if a patient has care source, we can't get anyone to fill a LAI unless it's a credo. Like we've always been told they have to go to a credo.
So that's CareSource is one of the managed care groups. So I'm sure somebody is on from that group. So they will they can select certain pharmacies or contract with certain pharmacies to utilize. That's within their contracting purview, which is a little different than the fee-for-service benefit. So again, if you have actual examples that you want to send over, you can certainly send them to me. I'm pretty sure my email is here on the last slide. Yeah, my email is there. I am happy to get them over to the state so that they can get to with the appropriate individual so that they can assess that for you.
Okay, I mean this probably happens like weekly. I honestly had no idea that when specialty pharmacies say we can't fill this, you have to send it to such and such. I didn't know that wasn't a thing. It happens all the time.
Yeah, so there's a lot of other insurance plans, et cetera, that are able to contract with specific specialty pharmacies. So they'll use specific specialty pharmacies, whereas in general, fee-for-service benefits is what they have a rule across most states, I would say, where it's any willing provider that's a Medicaid provider you can send to. But other insurance plans and managed care, et cetera, are often do that, contract with specific pharmacies. So again, send us your examples and we'll be sure to direct those. So just a reminder to the committee, you should have received an email from Courtney on our closed session. If you did not, if you could please let me know or let Courtney know. We will meet over there and begin at 10 a.m. For those on the open session, our next open session starts at 11 at the same invite. We may, I seriously doubt it, but in case we are running late, we will join as soon as we can. But given what's currently on the agenda, I seriously doubt that we will be running late. So we should be back over here at 11 for the open session. So with that, Dr. Shaw, I will let you adjourn us.
Hey, Amanda.
Oh, yep. Sorry, Mr. Ross.
Yeah, this is John. We're going to bring Dr. Shaw up to a conference room up in
Okay.
the OMPP area. So Namreed is down there fetching him right now. And but we'll do everything we can to be on and ready by the 10 o'clock session. So just to let you know.
That's fine. We'll wait for y'all.
Okay.
All right. All right. Well, we will see the committee over on the 10 o'clock session, and we will talk with everybody else back at the 11 open session. Thank you, and chat soon.